All right, so we're going to change gears. Shift in a second, and we're going to now switch to kinesiology. So moving more away from the actual exercise of the hip, which we're actually going to cover the next class in Therax. We're going to go through some exercises and stretches of the hip, to the goniometry, manual muscle testing, and theory of the hip itself. Sure. So Joe asked a good question. Joe asked, why is centralization good and peripheralization bad again? So that ties back to the last lesson we're talking about. With centralization, it means that the pain is moving back to its true area that caused it. Whereas peripheralization, like I think it was, I don't know if it was Diana or if it was Brooke that asked it, I can't remember, somebody asked it, said that peripheralization is really referred pain. It's pain away from the source. The pain, you've gotten so used to the pain in your back that it's now moving to keep you aware of the pain that exists. So as it moves back, that means that the pain is returning to its original source, and that means we can treat the original source. When it's peripheralized, it's hard to identify exactly what is causing the pain until we actually get it decentralized a little bit. Does that make sense? No problem. So we're going to talk about the hip. It's almost like we talked about a little bit ago. And we've got all these type of thought processes here already. The one thing different from kines is we want to think about what it looks like when we're moving between open kinetic chain and closed kinetic chain. When it is an open kinetic chain, meaning I'm sitting here and I'm flexing my hip and my distal segment is not fixed. Oh, that's a nice pop. It is a convex surface, so the femoral head moving on a concave, the acetabulum, because my femur is the part doing the moving. I think that's my labrum. Versus a closed kinetic chain, like when I stand up, it's my acetabulum, the concave surface, moving on the convex surface of my femur. So in open kinetic chain, it's vex on cave. In closed kinetic chain, it's cave on vex. So the motions we have at the hip, we have flexion, extension, and hyperextension. We have abduction and adduction. We have medial and lateral rotation. That's just kind of a review going through and that we talked about with, again, anatomy. Here's looking at the ilium, right? And looking at all those kind of bony parts of the ilium, including the fossa, the crest, the SIS, the AIIS, PSIS, PIIS. Again, all of those are typically muscle attachments. Then we got our ischium, which is kind of, I like to think of the ilium as our wing, the ischium as our butt or our foot, and the pubis is our body. The ischium has a body, it has a ramus, which is that kind of open area that goes over the obturator foramen. And we have our ischial tuberosity, which is really important because we have a lot of muscles that are almost just being hams to attach there. And we do have a spine that it's kind of out there with the kind of right along that sciatic notch, the lesser sciatic notch. It forms this little spiny point, which again is more muscle attachments. The pubis, superior ramus, inferior ramus exists. The pubis symphysis is where the two pubis bones come together, pubic bones come together. We have a pubic tubercle, which is where some of the more muscles attach. And then we also have, obviously, the acetabulum component of it. There's a lot on the femur, right? We talked a little bit about this in Therax. We got the head, we got the neck. We have the greater and lesser trochanters. And I always remembered with the femur, because it was always rough with me, remembering where the greater and lesser trochanter, and I don't know why, but I always remembered that the lesser trochanter is lower. Because the greater trochanter is here, the lesser trochanter is here, so it's a lower trochanter. We have the body, medial and lateral epicondyle, along with a medial and lateral condyle, because if you have an epicondyle, that means you have a condyle. You have the adductor tubercle. Gee, I wonder what muscles attach to an adductor tubercle. It's almost like the adductors. You have the linea aspera, right, which is that line on kind of the back side of the femur. And you also have the pectineal line, which I wonder what attaches there. It's almost like we have a muscle that goes along with that one too, like the pectineus. And we have our patellar surface or articular surface for the patella on the femur. Some of those surfaces will come back when we talk about the knee as well. The joint capsule itself, we talked briefly about it, but this is a really good picture that kind of illustrates that joint capsule. We have an iliofemoral, pubofemoral, ischiofemoral ligament. Excuse me. Those are the primary ligaments of the joint capsule. They make up this kind of yellow surface you see over here that binds down, and all of these different ligaments kind of wind around each other and lay over each other in order to form this capsule around your femoral head. There is also ligamentum teres, which is based upon its shape. The acetabular labrum, which is here, that deepens the fossa. There is an inguinal ligament and an iliotibial band. All of those are just common anatomy stuff you guys should have had last semester, but just a quick review. End fields at the hip. Almost all of your end fields when you're doing passive range of motion will be firm because of tension in the capsule, ligaments, and muscles. With an asterisk. Hip flexion may be soft because of contact with the front of the thigh with your belly, right? I probably have more of a soft end feel with that hip flexion than I have actually a firm end feel, because I can't reach firm because my belly gets in my way. Got to get rid of my belly so I can get a firm end feel. Goals at the gym. Muscles of the hip. Again, just to review these. The anterior muscles, we have our iliopsoas, our rectus, and our sartorius. And remember, with the iliopsoas, excuse me again, the iliopsoas is made up of psoas major and iliacus to form one muscle, right? In the medial compartment, we have pectineus, we have adductor longus, adductor brevis, and adductor magnus. Which one of those is the largest?
The magnus.
Yeah, it's almost like it's written that way, right? Magnus looks like it does to the adductor tuber, yeah. Magnus kind of attaches a little bit lower, right? It attaches more to the ramus than it does to the tubercle. And then we also have our funny one, gracilis, and I didn't, because I wasn't involved so much in your anatomy, I didn't get to tell you my funny story when I think of this, because I had an instructor that was kind of funny when he taught us this. The gracilis is a muscle that if you follow it north, and he takes you to Graceland, where you might meet the king or the queen. Some of you, okay, some of you got it, good. All right. The gracilis leads us to Graceland. Posterior muscles, we have our glute max, which is our big, broad muscle that is our hip extenders, right? We have semimembra, semitenda, and we have our biceps. We also have our deep rotators. And remember, I mentioned this briefly, and here is all those deep rotators, the deep six. We have obturator internus and externus, piriformis, superior and inferior gemellus, and quadratus femoris. They all act as a group. What do you have to, and now the students are going to freak out because I just gave you like 6 new muscles you didn't learn before. The good news is they act as a group. They work on either internal or external rotation of the hip. You basically just have to know these by name. Know that if a question on the boards is talking about the gemellus group, that would be gemellus superior and inferior, it's talking about muscles that perform rotation at the hip. Does that make sense? So don't totally freak out. You don't have to learn new origins, insertions, actions, innervations. You just have to know the names of the muscles that make up the deep six. And again, I like to look at this and go, okay, well, this isn't as hard as it looks, because in reality, I only have to remember 4 muscles, right? I just have to remember obturator, piriformis, gemellus, and quadratus femoris. So it's not as bad as it looks. Lateral aspects, so out here on my lateral hip, part of my hip, I got my glute med and my glute min, and then I have my TFL, and that attaches onto that IT band. So what happens with structural variation of the hip? Well, we can have two different things called femoral anteversion and femoral retroversion. So when we have a normal hip, right, the femoral neck is going to be in line with that acetabulum, and it's going to come straight out and kind of form this nice angle. But if that femoral neck, meaning the neck coming from the head of the femur out towards the body of the femur, sits a little bit more forward or leans a little bit more anteriorly. So again, if I'm standing up here, and if my hip, they kind of come more like this rather than keeping at the angle going straight out, what you're going to end up with is your toes pointing inward. So femoral anteversion leads to toe in, your toes pointing in. Versus femoral retroversion. Now that femoral neck leans a little bit more backwards. And this may help you guys because this, I'm an excellent example of this. Just remember that femoral retroversion is what I have. My feet are like penguin feet. They point outward, right? So that leads to toe out. So,
sorry, are you saying that it's like, it's just because it's like rotated in, like, so the anteversion is rotated inferiorly and then, or interiorly?
So what happens here, so here we have, with this picture here, we have a normal femoral neck where it kind of goes straight down this line. When that neck kind of rotates anteriorly, instead of just having this normal straight line, the neck kind of goes like at that kind of an angle, if that makes sense. That is femoral anteversion, going anteriorly. And when that goes in, if I go down to my feet down here, my feet end up pointing in towards the center, or called toe in.
Is that just like due to like muscle tightness or weakness or something like that?
That's where actually, that was a great question. That's where I'm going with next. It can be due to muscle tightness or weakness. It can also due to a structural deformity, meaning that the bone literally grows that way. That's what I have. Mine's not actually muscle weak. Well, I mean, I'm sure that muscle tightness plays into it because I have really tight piriformis. But mine is actually structural, that my femoral neck kind of is shaped weird, if that makes sense. And we're actually going to talk, so valga and varus are a little bit different, Joe, so great question. I'm actually going to talk about that in a little bit. They do tie into this, but not as much as you would think. That ties more into the angle of the actual, the femoral shaft itself. We're going to talk about that in a few seconds. So it can happen to weakness, right? So let's say that if this is my posterior aspect, and this is my anterior aspect of my leg, and these muscles back here are really tight, well, that's going to pull my femoral neck back this way, right? And that's going to get me a retroversion effect. Whereas maybe if my anterior muscles get tight and pull that head forward, I can end up with a toe in effect. So if we catch it early enough, especially with kids, we can treat it, right? We can stretch them, get them to where their toes are neutral or kind of pointing straight forward. Because I'm going to speak from experience, running with your feet completely turned outwards is an experience. It's not like normal running. I have to work at having a normal gait cycle when I run. And so my energy conservation just isn't as high. It means it takes me a lot more to run than it should. And let's just face it, I don't need any more help. I'm kind of big and running is not the best thing for me. So what I also like to think of is that ants like to get in your house. So ants lead to toe in, right? Whereas if it's retro, it's out of style. So retro leads to toe out. That's going to be a board question. I guarantee it, right? They're going to ask you something about femoral anteversion leads to what condition at the foot? Femoral anteversion leads to toe in, right? Versus femoral retroversion leads to toe out. And they're probably, like Joe asked there, going to add the valga and the vera in there, and which is going to add to confusion. They're going to be throwing coxavera, coxavalga as an answer. You might get confused, but anteversion, retroversion don't have anything to do with coxavera or coxavalga. So we're going to talk about that in a bit. So like I said, ants get in your house. So anteversion is toe in, retro is out of style. So femoral retroversion is toe out. Now we get to coxavera, coxavalga. So this is more dealing with the actual angle of that femoral neck coming to the femoral shaft itself in a verticality type idea. So if the angle is less, the femoral neck sits closer to a 90-degree angle, that is coxavera. It is a very close angle, coxavera. Versus coxavalga, the angle actually gets greater. So the femoral head kind of sits at an angle like this. Versus coxavera, the femoral head kind of sits at an angle like this. Right? So the normal angle of inclination is about that 130 degrees, which we talked about. Well, actually, that's really good. So we do have genuvera and genuvalga at the knee. And I'm going to give you a little secret here, because sometimes they will tie coxavera and coxavalga to the knee. So let me give you Mr. McKeever's little dirty secret that helped me get through this. That's okay. So here's my feet. This is my knee. This is my hip. Right? Remember, hip is coxa. Knee is genu. So if you have, I'm just going to use the left leg here. If you have valga at the hip, so you have coxa valga at the hip, the knee is going to go into genuvera or genuvera. So it's going to flip. So if I have coxavalga at my hip, I'm going to go to genuverum at the knee. They're going to flip on it. Does that make sense? Not necessarily about why it happens, just the rough kind of idea. The ankle, right, will follow the knee. So the ankle will be a varus angle at the ankle. So you have, and we'll talk about the ankle varus in a bit when we get to the ankle. So whatever happens at the hip changes at the knee, the ankle matches the knee. So how would that look on a board question? The board question might say that your patient presents with coxavalga at the hip. You're likely to see what deviation at the knee. If it's valga at the hip, it's vera at the knee. Genuvera. Good. Controversially, if I have vera at the hip, then my knee and my ankle are going to be valga. Does that help at least make sense of those? Not necessarily understanding why it happens, but at least. So this normal angle of inclination, let me come over here and clear this that way. Erase this stuff here. So my normal angle of inclination when I'm dealing with this, so when you're looking at it, it's this angle right here. It's greater than 90 because there's 90 plus about another 30. So it's somewhere between 120 and 130 is about what the books say, depending on your book. I usually go by 130, but it's somewhere between 120 and 130 is a safe normal angle, John. The closer it gets or past 90, that's where you get the vera. The greater over that 130, it goes to valga. Did I lose anyone?
No, but I do have a question. So you've got coxa valga, genu vera, and then if it's, what's the word for the ankle?
I'm drawing a blank right now. I know it's on my lecture. That's why I kind of skipped that. Dang you.
Sorry.
I want to say it's calcaneal, if I remember correctly, because I think it goes with the calcaneus. I know it's a great question. I don't have that lecture handy right now, so I'm pretty sure it's calcaneal because it goes with the way that the calcaneus sits when you get down there, right? Which can then also lead to pronation or supination.
But it'll also be called the same thing as what the knee is?
It'll just match the knee. You're exactly right. So it'll be, you know, if your knee is a vera, the ankle's a vera. If the knee is a valga, the ankle's a valga. It's pretty rare. You know, like there's a 1% chance that it might be opposite at that area. And that's not going to be a board question. They can't ask you about silly stuff like that.
Okay. And is it like calcaneus vera or?
I'm pretty sure it's calcaneal vera, calcanea valgus. Let me find my tablet here real quick.
That's okay.
You guys, well, no, that's a good question. It's just been, I was working on that lecture last night and my brain is kind of melted down. Yes, it is calcaneal vera and valgus. I should have prepared for that. I should have known Riley was going to hit me up with that question. But again, the main thing to understand is that the hip goes one way. Once you get down to the knee and the ankle, it flips. So if the hip is a valgus, the knee and the ankle is a varus. If the hip is a varus, the knee and the ankle are a valgus. That makes, at least that part of it makes sense. And we're going to talk about why that happens when we get down to the knee and looking at the line of pull when we change the angle at the hip. Remember that when we have a structural anomaly, like we have back here with coxa vera and coxa valga, we can't fix that by stretching. That makes sense, right? We can't stretch bone. So we can't fix that. If we have soft tissue issues like muscle, tendon, ligament, we can fix that by stretching. But if we do have a structural variation, we have to assess, and when I say we, I'm talking about PT in general, not PTAs, right? We have to assess, is it causing them pain and decreasing mobility? If it is, it has to be addressed. If it's not, leave it alone, right? Because I've got femoral, like I said, I've got toe out on my thing, so I've got femoral retroversion. It doesn't cause me problems with my normal everyday life. I can walk fine. I just look funky when I'm walking across a quad in the snow. I leave little penguin trails going through the snow. I think probably it had something to do with the martial arts at an early age as well. I'd be willing to guess, doing a lot of straddles and splits and stuff like that. But because it's not a problem, I'm not going to worry about it. But if a patient came in with coxa valga and they're having problems with mobility and problems with pain, then yeah, we're going to have to look at it and see how we can improve it. They may have to get surgery. So we'll address it as appropriate. So what I have here is a couple surgeries. We're actually going to watch these surgeries next class, so I'm not going to watch them right now. I will warn you guys. I'm going to warn you. So we're going to watch this on Monday, right? Monday's next kines class. I would highly recommend, if you are queasy or easily made nauseated, to pay attention to thinking about what happens, because I've had students throw up when I show these videos. Because especially the total hip replacement, then they start doing that, it gets a little gory. But here we have an open reduction internal fixation, the one with the picture at the top, right? This is an ORIF. This is what a total hip replacement should look like when it's finished. Do you think we have a problem here?
Yeah, might have missed the target.
Yeah, a little bit of missed target, right? What do you think happened there?
Maybe dislocation?
Yeah, this was an actual intentional dislocation. The patient was intentionally dislocating their hip in order to sue the hospital. This is not my patient, but my patient was very similar to this. Yeah, what? We had a guy that came into one hospital that I worked at here in Vegas. he had a posterior total hip replacement. And every time PT came in to see him, he was sitting in a chair, kind of hunched over like this, with his leg crossed across the other one and his toes turned in. And we'd get him up to move and the hip would dislocate. We'd go over his precautions with him. What are your precautions for your hips? Well, I can't bend way far over, I can't turn my toes in, and I can't cross my legs. Great, we'd come back, his hip was dislocated again. When he was in the hospital that I saw him, they had to relocate his hip 9 times in a week. And let me tell you, that's not a pleasant feeling for that ball to go be way that far out of the socket. About a year later, it don't feel any better. About a year later, I get an email. He had sued the hospital. He had sued the surgeon. He had sued the physical therapy company because the company I worked for wasn't employed by the hospital. We were a contract to the hospital. He had sued every physical therapist and every physical therapist assistant that went in to see him, and nursing, because nursing was actually a contract group as well. So he sued all of us individually. Luckily I have, what do you call it? I have a liability insurance. My liability insurance said absolutely not. They looked at my notes. In my notes, I talked about reviewing my hip precautions 2 times with the patient. They're like, this is his fault. We're not paying anything. He dropped the suit. He actually dropped the suit against all of the PTs and PTAs and any stuff. Guess what the hospital did? Hospital paid.
Settled.
Yeah, right. They settled. Why do you think they settled?
Cheaper than litigation.
Yep, it's cheaper than litigation, and it's a lot better than bad press. Right? Because the number one thing, if he was doing that constantly, where do you think the next place he's going to? He's going to like LV Action News 8 to talk about how bad the hospital was for surgery. Right? And then, you know, that leads to all kinds of other problems. That leads to patients not coming. So that was just cheaper. The doctor, I think if I remember correctly, did not settle, but he ended up having to pay in the end because somehow or other the lawyer convinced the surgeon or convinced the judge that they used the wrong size femoral component, and that's why it kept dislocating. So the surgeon had to pay in the end anyway through his liability insurance. This is why insurance is so expensive. Yeah. Ironically enough, you're exactly right. Harvey Specter would have won that case, no problem, right? Ironically enough, from the hospital, he settled for about $400,000. I think he got another $150 from the doctor, and there were some other kind of minor things in it. Ended up being like almost an $800,000 lawsuit, right? The downside to that is, yeah, I will actually talk about that this semester. I do recommend carrying liability, even if you're in a clinic that carries it for you. It's just safer. And for me, like my liability insurance is like, I think $90 a year, and it's like a $5 million liability waiver. So I'll pay $90. Yeah, right. I'll pay $90 to have that little bit of peace of mind that I've got a lawyer on my side. But anyway, so he settled like about $800,000. The amount that he ended up getting was like, I think like $190,000. Where do you think the rest of that money went to?
The
Lawyers.
The lawyers. Yep. Lawyers and fees. So, I mean, just saying, I don't know. But yeah, I was kind of sad the hospital settled with them. So it is a real thing. Malpractice happens, and well, malpractice happens, but also kind of litigious patients happen, meaning they like to sue. You know, you can tell those patients before they ever like sue you, because they'll be asking you, so have you ever been sued before? That's a red flag. Like red flag number 1. So how did you settle those suits? Red flag number 2, right? Those are when you go talk to your PT and go, I think this patient's looking for a free payday. But we will watch these videos. There are some great videos. We'll watch them on Monday. With the arthro or the joint kinematics of the hip, open packed and closed packed position. Open packed position is about 30 degrees of flexion. 30 degrees of abduction, and slight external rotation, meaning just kind of letting the leg drop out. If I'm in this position here, it's really easy for me to mobilize the hip. Closed pack is when the leg is in full extension and has a little bit of medial rotation where that socket or the ball of the femur is in that socket nice and tight. Yes, you can refuse patients. So how do you say that? You mean, what do I say to patients, or what are you talking about there, Brooke? I'll answer your question, Diana, in a second.
Like if someone asks, have you ever been sued? What do you say to that?
I'll say, no, I've never been sued before. And it's quite a shame. I'd really like to be sued. No, I don't say that. I said, yeah, I've been sued a few times and I've won all my cases. That kind of puts a little bit of fear of God in them. Because, or I'll just say that it's not appropriate to talk about. Are you concerned with my ability to treat you? Right? And yes, you can refuse patients, Diana, and I have refused patients in the past, but I tend to like those patients that people refuse. Same idea. I had another total hip replacement, and this is a true funny story. Total hip replacement in the same hospital. Actually, now that I think about it, the exact same room that guy was in. Grumpy, just mean patient, and I drew her out of the pile of patients to go see for the day, and I go to the door, and there's a sign on the door that says this. That's what the sign says on the door. So you can figure out what she was trying to say, I assume. Brooke's laughing, right? And I go to the door and I see that, and the nurse is like, what are you doing? And I'm like, she wants help, right? Yeah, she's in here, she's in for surgery, she wants help, but she's got some bias going on, right? There's like, anytime we send a doc in there like that, she's screaming at them, she's throwing stuff at them. So I knock on the door and I go in to see her. And, I knock and I say, hey, hi, I forgot, Mrs. Johnson, I don't remember what her name was. I'm Keith, I'm from physical therapy. I'm here to get you up and out of bed and get you home. And she looks at me and she's like, the whole head whip happens, like Smog from Lord of the Rings. And she's like, did you not read my sign? And I said, oh, the sign, I didn't think that applied to me. And she's like, what do you mean? I'm like, well, I said, technically, I'm half Native American, so technically I'm pink. So I thought I'd be okay to treat you. And ironically enough, she just started dying of laughter. And just like literally had like, the snot bubbles kid type laughter, that was where she was. And she worked with me. She wouldn't work with any other therapist in the building, but she worked really hard for me. And what it just really was is she felt that the people weren't listening to her. That was all her problem was. She felt that the docs were just coming in and talking at her versus listening to what she was saying. So I spent 5 minutes sitting in a chair. Okay, tell me what you want. What you really, really want. Tell me what you want. What you really, really, no, just kidding. I just sat there and listened to her for 5 minutes. She went off on a tangent for 5 minutes. I said, okay, great. Do you want to go home? Yeah. Okay, if you want to go home, the route home is through me. And sure enough, she got up. We walked through the hallway twice. She actually became a better patient after that because we found out what was bugging her. I could tell the nurse what was really bugging her. She felt like she was being ignored. And when we did that, we changed the way we approached her, and she became a model patient for the most part. But that could have went sideways anyways. That's why I say sometimes do as I say, not as I do, because I get away with quite a bit of stuff. She could have thrown a planner at me, but she started laughing. So yeah, so open pack, 30 degrees flexion, 30 degrees abduction, slight external rotation, closed, full extension with medial rotation. And we talked about capsular patterns. A capsular pattern, there is a marked restriction in medial rotation accompanied by limits in flexion and abduction. So I've got some internal rotation problems, I've got some flexion, and I've got some abduction. Again, if I just have flexion problems, that is not a capsular pattern. If I just have abduction problems, not a capsular pattern. If I have external rotation problems, not necessarily a capsular pattern. But if I have something like medial with a little bit of flexion and a little bit of abduction, probably capsular, which means if it's a capsular pattern, what do we do with capsular patterns again?
Mobilize.
Mobilize. Yeah, right. Yeah, I mean, so Diana asked, does it have to be two? Ideally, most times there's going to be about at least two motions that are limited. So, you know, if I've got somebody that's got medial rotation and flexion as a problem, I might think it's capsular, but it could also just be musculoskeletal. So I have to kind of play around with it and figure out what it is. The PT also has to kind of play around and figure out what it is treatment-wise. Right? But if you've got all three, for sure, that's capsular. I mean, I can count almost every time I've seen a patient that's been kind of limited in medial rotation, limited in flexion, limited in abduction. They've all been capsular patterns, usually been of the iliofemoral ligament. So I'm going to get in there and I'm going to do some posterior mobs and really kind of work at that joint. And suddenly they're like, man, my leg feels 100% better. Well, good. Send checks to. No, just kidding. I wish we could say that. So what are our range of motion values? This is where we start getting into the stuff you're going to have to start writing down some note cards for, folks, or a spreadsheet or whatever helps you. The range of motion values I want you guys to remember is that flexion is about 120 degrees. So what does that mean? If this is my leg, so here's my hip, here's my knee, here's my ankle, here's my foot. When I go up into flexion, right? This, well, that's the knee. Don't do that. This would be 90 degrees of hip flexion. You should have a little bit past 90 degrees and be able to go to about 120 degrees of hip flexion. Now, could there things that be limited? Could there things be limited? Yeah, my brain's working. Could there be things limiting things? For sure. It could be soft tissue approximation. Their hamstrings are really tight. All of that could come into play. Anthony's like, yeah. Anthony, is it musculoskeletal limitations there?
Yeah, probably.
Yeah, probably hammies, right?
Mr. McKeever?
Yep.
I'm sorry, I'm having a hard time like with the picture. Could you demonstrate it? I'm
Absolutely, sure.
sorry.
No, that's fine. Ugh. Move my stool back out of my way here so I don't kick anything. So with flexion, let me bring the camera down some. There, oh, I think I can tilt it a little bit more by adjusting the grip. Work for me. Hold on here. What am I doing? There we go. No, stay down. There we go. All right. So with hip flexion, right? So this is 0, straight down. Let me move this a little bit, right? Okay. 90 would be about here. Now I moved it down too low. There we go. So 90 would be about here, where my hip, my body makes an L, right? That would be a 90-degree hip flexion. So about here. Normal would be 120, and like Anthony, I'm pretty limited to about 90 degrees. Right? So with my knee extended, I'm limited to 90 degrees. Now, if I bend my knee, now guess what? I can get to 120.
Okay.
Why do you think that is?
Just because I would just think because you're extending your limb and it's like a little heavier, I guess.
Well,
Passive insufficiency.
yeah, it's the insufficiency of the muscles, right? When my knee is extended, my hamstrings are all stretched out, right? Because it's coming, they cross over the hip joint, they cross over the back of the knee. They're completely as long as they possibly can be. And if I'm tight, which I am, my hammies are super tight, I can't pick that leg any higher because the hammies are saying, not today, right? I'm gonna talk about that in a second, Amanda. We're gonna talk about positioning. I'm just kind of doing the demonstration right now, and then we'll talk about positioning. Whereas if I bend the knee, now I've put a little bit of slack on those hammies. And now I can bring that hip up a little higher because the hammies have a little bit more range of motion because they have some slack because they're no longer straight at the knee. So that depends. So when we measure this, John, we're going to measure it with the knee extended. So you should have 120 degrees knee extension at that point. That's ideal. You should also definitely have 120 knee flexed. And I guarantee probably if we check everybody, we can probably get everyone to 120 knee flexed, right? And I'm right there with you guys. I got to stretch my hammies out. And what we'll talk about also is that the main problem there is either A, sciatic, or it could be hamstrings. And mine's a combination of both. I start getting up past that 90 degrees, my hammies start screaming at me, but also my butt starts going numb because my sciatic is really tight in my piriformis. So Amanda asked, are we going to measure the test supine? Absolutely. So we're going to have the patient lay back on their back. We're going to passively move them into hip flexion. And in reality, with the knee extended, we call that a muscle length test as well, because we're testing the muscle length of the hamstrings. So we're going to check it with the knee extended, and then we're going to flex the knee and check it with the knee flexed. If we get to 120 with the knee flexed, that tells us what about the hamstrings?
Really tight.
They're really tight. Yeah, right. And I've had patients where with the knee extended, I get them to like 45 degrees. They're that tight. And then I bend that knee and they've got like 100 degrees. Like, man, your hammies are tighter than an NFL kicker. So yeah, and we'll talk about muscle length test as well when we practice, but a muscle length test is where we're seeing how far that muscle can kind of stretch out and become passively insufficient. But yeah, we're going to test that one definitely in supine, right? Because the only thing we want to move is that leg. Anything else we move would be kind of superfluous, I guess would be a good term, or unneeded motion. We're also going to watch to make sure that that pelvis doesn't get out of whack. So the next thing we're going to test then is hip extension. If we tested flexion in supine, we're going to check extension. So this is a supine activity. We're going to check extension in what position do you think? Prone. Good job. We can also test it in standing if the patient has standing tolerance for it, but I still test them in prone because it allows them to relax a little bit more. You should be able to extend back about 30 degrees. Get my hand out of the way. Right? You should be able to extend back about 30 degrees. Now, you see, I'm cheating a bit because as soon as I start extending back, what does my trunk do?
It leans forward.
Go forward.
Yeah, that's why I like to test it in prone, because if I'm laying on my belly, I can't lean forward. Right? That won't let me that won't happen. Silly camera. So 30 degrees going back. What muscle might limit that? Hip flexors. Good. Yeah. Iliopsoas is a big one, right? And also rectus, theroneoculitus femoris. And that one, if we bend the knee, it actually makes it harder because when we bend the knee, we've stretched out rectus femoris a little bit further, right? You guys have all done that stretch in the gym where you grab your foot back here, right? And pull backwards. And you get that nice stretch going down the whole front of your quad. That's a rectus femoris stretch. Abduction and adduction, both of these are done in supine. And they're going to be typically done together. So I'm going to test abduction. and then I'm going to test adduction. Right? So you should have. So you're going to do opening the leg, taking the leg away from itself, and then you're going to go back across. So you should have about 45 degrees of going out, and you should have another 30 degrees of going in, crossing over midline. Now you're going to have to move the other leg out of the way. So you have to extend that out into abduction a little bit to give you range to get 30 degrees. But they're both tested in supine. Excuse me. Medial and lateral rotation of the hip. There are two different ways you can test this. The easiest way I find to test this one is short sitting. You can also test it in prone, but I find short sitting is easier because what I'm going to do, let me just take my camera here and take it off and take it down here. Give me some length. There we go. Thank you. Hi, you're coming closer to me. Stuck on my computer. There we go. Right? So what I'm going to do is if I'm sitting in short sitting, going that way is internal rotation of the hip. Going that way is external rotation of the hip. I can use my tibia as a good guide on how much range of motion I get on internal and external rotation. So we'll go through the techniques. That's going to be one of our next classes too, is going through each of these, and I'll demonstrate how to do goniometry for each of these motions. You can also have the patient prone, have their knee flexed, and have them go in or go out based upon what you need. So those are your norms that you need to have in your head. So eventually your brain should be like, okay, flexion of the hip is 120 degrees, extension of the hip is 30, abduction is 45, adduction is 30, medial and lateral rotation are both 45. Those are norms. If you're abnormal, then typically we've got some problems, right? You might be tight, or there might be a capsular problem. In order to do things functionally, meaning walk around, go upstairs, go downstairs, at the hip for walking on a level surface, so just walking on a floor, you need about 30 degrees of hip flexion and about 20 degrees of hip extension. So your hip needs to come up about 30 degrees and needs to swing back about 20. That's not really, if you look, right, you're supposed to have 120 degrees of hip flexion. So you only need 30 of that to be functional for walking. Supposed to have 30 degrees, you need about 20 of that for functional walking. And ironically enough, once we test most people, most of you only have about 20 degrees because you'll find out that your quads are tight or your psoas is tight, limiting you. To go up and down stairs, you need about 60 degrees of hip flexion. There's not really a necessary extension component to that, but you do need 60 degrees of hip flexion to go up and down stairs. So these are your goniometric norms. So these are what you need to know for goniometry. So if Truman is measuring John, and he's measuring John's hip flexion and gets, 85 degrees of hip flexion, Truman should know that John has a limitation and he's short on hip flexion. Again, do you have to note the difference? No, because these norms are just normative standards. You don't have to put in your assessment, patient has, that would be 35 degrees of hip flexion missing. No, we know what the normals are, or at least most clinicians do. And I'd be willing to bet if you actually ask most clinicians, they know the norms of the muscle or the joints they treat most frequently. Like if you ask a back physical therapist or physical therapist assistant what the finger ranges of motion are, I'm pretty sure they're going to tell you they have no idea. So you kind of do get kind of zoned in on the area that you treat the most. I've treated a lot of hips and knees in the neuro setting, and so I'm used to looking at these. So the PT is going to say if they eval this patient, so they eval John, John's at 85, the PT then has to go, is it an MSK problem? Is it musculoskeletal? Is it neuromuscular? Is it cardiovascular? What's causing him? Or is it a combination of all three of these? Or is it just skeletal alone? Is there a bony block? What's causing him to be short? Those 35 degrees.
How would a cardiovascular cause a range of motion
Sure,
deficiency?
that's a great question. So again, remember, here's my femoral head, my femoral neck, femur, right? There's my kind of change. What if the blood supply going to this femoral head is off and I lose half of that femoral head? So it dies. And now because of that, I've got all kinds of scar tissue in that area because I've got broken down, you know, necrotic tissue plus died off blood vessel plus stuff like that. That could definitely limit me cardiovascularly. More importantly, a lot of times our cardiovascular problems will happen in the upper extremities more frequently. Now, it's kind of rare in the lower extremities to be a CV problem, but up in the upper extremities, especially with thoracic outlet syndrome, it's really common for cardiovascular problems to cause shortages in range of motion. Because the blood supply, you know, I get here and all of a sudden my blood supply is getting cut off and my muscles aren't getting enough blood to go the rest of the range. Right? That could happen too. Does that make sense? So yeah, it's interesting when it happens. So these are the norms you have to memorize. Manual muscle testing. So we're going to go through the text. Again, I'm going to go through each of these. We're going to go through, I'm going to demonstrate a manual muscle test of the hip. I'm going to demonstrate a goniometry of the hip. I'm going to demonstrate an extension of the hip for manual muscle testing goniometry. And then when we get to lab, we're going to do them. Absolutely. COVID could have patients affected for sure, John, right? It could even, could it be, I mean, I would be willing to bet you could probably even do a little bit of looking into that. It may be an oxygen deprivation. So even more than cardiovascular, it could be cardiopulmonary, meaning they're not getting enough oxygen out to their muscles to allow them to move range of motion. Sure. I mean, that may be coming down the line that we just haven't even seen the effects of that later yet, right? It could be years until we see the effects.
How do you normally take that out, like cardiovascular or cardiopulmonary? Like that's not where you're lacking, or how do you?
A lot of times, if they've got a cardiovascular problem, there are going to be other signs that go along with it. So let's take the legs, for example. If I've got a cardiovascular problem with the legs, a lot of times I'm going to have either sores on the legs, I'll have edema, or I'll have a thing called claudication. That's where when I raise my legs up, they start aching. And that's caused by peripheral artery disease, right? So if I had, if I'm doing range of motion and the patient's complaining about pain in their feet when I move them through the range of motion, I'm like, this might be a cardiovascular problem more than it is musculoskeletal. I may need to send them, the PT, I don't want to say me, I'm talking the clinic, may need to send them for a cardiovascular consult as well as seeing them for PT, right? If it's musculoskeletal, it's usually because you're going through and you're like, oh my God, I can't move John's leg, it's so tight, right? You can usually, by the feel and by what's happening, it's pretty rare that you get a cardiovascular issue, but it's possible, right? And then neural issue, you'll know because they're saying, I'm trying to move it, but it's just not moving, right? That's a neuro issue where it's just not allowing that signal to be sent. So we're going to go over the goniometry and manual muscle testing, but let's think about this for a second. Let's just think about some landmarks for this. What do you think are some important landmarks? Give me a list of some important landmarks we probably need to know for manual muscle testing and range. Okay, so I got ASIS already. Somebody fired one off. There we go. Good. It's one of our big ones. That one's going to be important for specifically abduction and adduction. Greater troch. Yep. That's going to be big for flexion and extension, right? I already said the tibial crest or the tibial line. What is that called? Yeah, tibial crest. That's what I was looking for internal and external rotation. But remember, if I've got a tibial tuberosity, could be one. Yep, absolutely. Tib 2. If I'm doing hip flexion and my greater trochanter is my rotation point, I've got to have a distal point too. So where down on the femur might I use my distal point?
Lateral epicondyle.
There you go, the lateral ep, right? So for sure, lateral epi. Right, so we're going to go through that. We're going to go, okay, so I'm going to line up, you know, for example, I'm going to use hip flexion as an example. I'm going to line up my fulcrum, tip it down a little bit again. Line up my fulcrum with my greater troch. I'm going to line up the stationary arm, and the stationary arm actually for that one is going to go parallel to the trunk of the body. Whatever. Lateral malleolus is another one. Good, Truman, right? And then I'm going to line up that other one that it kind of lines up with my lateral epicondyle. So when I move through, I'm going to measure off my lateral epicondyle how much motion I've actually gotten. And then the other thing we'll talk about is some muscle length testing. These are the ones that almost all of you will hate at some point. I'm pointing down to my arms, pointing me back to my face. The muscle length testing, when we do these, like the Thomas test, the over test, the modified over test, these are testing to see how much length our muscles have, and is it a length problem that's causing us a range of motion problem. Does anybody know what muscles the Thomas test tests? That sounds bad. Thomas test tests?
Is it the rectus femoris?
Yeah, rectus femoris and quads. Yep. Good. And again, this is just kind of seeing where you guys are. Straight leg test. We kind of already did that. Straight leg test is testing the length of the what? That's keeping the leg straight. And moving
hamstrings.
Your hammies, yeah, hammies. And this, the modified over and the over, I like to think of them as I'm going to bring my one leg over the other and drop it off the table. Does anyone know which one that's a test of tightness for?
TFL?
TFL, good. Yep, TFL or IT band tightness, right? So we're going to do all of those, but I find when we start getting into those tests, those are the ones you guys won't like at all, because everyone's, I mean, we're going to have probably at least half the class that has tight IT bands. We're going to have a good chunk of the class that has tight hammies, and we'll have definitely a good chance of the chunk of the class that has tight quads. Just because that happens, right? We all are built a little bit differently. There are plenty of other muscle length and special tests we'll talk about. But those are kind of the main ones that we're going to hit when we talk about the hip. SLR stands for straight leg raise. And it's testing for length of the hammies. So again, try to turn a little bit here if I can. Just so I can give a quick demo. Tilt the camera. Tilt the camera. So if I'm laying back on the mat here, right? Straight leg test, I'm going to bring the leg straight up into the air. I am definitely not even hitting 90 degrees before I start getting tightness. It ain't happening. Right? Thomas test, in this case, I'm going to lean back. I'm going to have my butt kind of out here on the edge of the mat. And again, you don't have to know this 100% yet, but it's just to kind of demonstrate it. I'm going to grab my one knee. I'm going to pull that knee up. And if I pull that knee up and the other leg comes with it, like mine do, that means my quads are tight. Because again, this leg should stay on the ground if my quads are nice and loose. And I'm actually resisting right now, so that's why it's staying down. But if I don't resist and I just relax that leg, they kind of pick up together. It's a magic trick. You can absolutely wear leggings to laugh. Sure. I don't know why you'd want to, but yeah. The IT band test is one where we're going to kind of lay on our backs. We're going to take one leg. Like I said, it's an over test. You're going to bring one leg and drop it kind of over the other. And I can't do it in the hotel room, unfortunately. It's not enough space. And we're going to test for IT band tightness. And then that gives us, does that give us stuff that if we find out, oh, look, his quads are tight, does that give us stuff to work on? Right, yeah. And what's funny is for most of these tests, the Thomas test, the straight leg test, and the over test, we can turn those right into a stretch. So the Thomas test, I can push down on the leg that's popping up, and that becomes a stretch. The straight leg one is already a stretch, right? Bring that leg up and stretching out that hamstring. The TFL one, I can bring that over and put a little bit of over pressure on the leg and get a good, nice IT band stretch going on. So that's the one nice thing about the muscle length tests is if you locate that they've got a length problem, you can convert that into a stretch really easy. All right. Whew. That was a lot of stuff. That was a lot of frying of your brains today. I can see Riley's brain is just like, I need dinner. My head is done. I got pulled pork waiting for me. So yeah, I want some dinner too. I think when we do this, so on Monday, when we get back into Kines, what we're going to first of all do is kind of watch a few of those surgeries, just so you can kind of see what's going into it. We're probably not going to watch it on slow speed. We'll probably watch it on a little bit advanced speed because we don't need to sit and watch for 20 minutes of surgery. It's not what we're doing. But definitely I want you guys to kind of see what happens when they do the surgeries. And then once we've done that, then I'm going to run through all of the basics of how to do range of motion of the hip, how to do manual muscle testing of the hip, how to do range of motion of, flexion, abduction, adduction, so that we've practiced a little bit. And then when we get in lab, we're just going to be like Nike and we're just going to do it. And we're going to practice on each other and we're going to get through this. And you guys are going to go out in the field and be like, yep, we just covered this. I know how to do range of motion. I know how to do goniometry. Let me at it. Give me that goni. Right? Because again, your first clinical, and I actually had I forget who stayed with me about this on last class. I think I don't even know who it is. I'm not going to call them out. Your first clinical, you're not expected to be perfect. I mean, I know that Stephanie's perfect as she is, but you don't have to be the perfect clinician on your first clinical. You're expected to be able to follow a flow sheet, do some basic exercises, and do some basic testing on your first clinical affiliation, right? You're not supposed to know how to progress every patient, how to regress every patient, know what the difference between a Parkinson's with dopamine medications on board versus Parkinson's without dopamine medication on board patient looks like, right? But you should know safety. You should know if you're working with a Parkinson's patient, you need to have a gait belt on, right? That type of a thing. You should know how to do marching with a Parkinson's patient. All of those stay the same with basic exercises. So don't freak out. Your first clinical, your 2-weeker is dipping your baby toe in the water of clinics. And then after you dip your baby toe in the water, the next clinic is going to hit you like a freight train, because then you're going to start progressing the patient, right? You're going to be expected to go, oh, well, he's doing quad sets really good. Let's move him to short arc quads, right? Getting the patient up and moving more frequently. You're going to expect it also on your first clinical to be able to transfer a patient, which is what you're going to work on with Dr. Sokel, right? Wheelchair prescription, another great one. That is a pretty much only PTA job. We actually we'll do in 4th semester or 5th semester, depending upon when UNLV wants to do it. We'll do a session where you guys will get together with the senior class from UNLV. They're DPT students. And you guys will talk about what do they know versus what do you know. And it's funny, the number one thing that comes out of it is DPTs don't know anything about wheelchairs at all. They know how to put a patient in them, and that's about the extent of what they know. They know they have big wheels and little wheels. You guys are going to learn all the parts of the wheelchair, what parts you need to order for certain patients, That's a really specific PTA kind of task. That's one of the areas I actually am proud. That's one we can keep because PTs don't want that. They're like, you, fine, order the wheelchairs. I don't want them. Right? And we know all the gait patterns. Sometimes the PTs don't know all the gait patterns. They kind of forget over time. So, whew. All right. Anyone ready for dinner?